This is Just Say HIE, the official podcast of the Hope for HIE Foundation. I'm Betsy Pilon, your host, bringing the stories of the HIE community from around the world to you, our listeners. Hope for HIE is a nonprofit organization and the largest collective of HIE families anywhere in the world, and each story across all outcomes has its own version of hope to share. Join us as we explore each unique journey and connection. I'm really excited to welcome today Dr. LaTrice Dowtin, who is the owner of Playfully Psyched, right?
Mm-hmm,
Your own private practice, and you are a perinatal mental health counselor, and you serve on our medical advisory board. And we're so excited to have you here to talk during Mental Health Awareness Month about this really important topic about trauma-informed care, about reducing disparities, and, really focusing on different types of support that's available for families.
Absolutely. I'm excited to be here. My first ever live. So excited to be here with you all.
Wonderful. And if you want to give just a little bit of information about your background and your passion projects and all of that, I know that we've been chatting a lot over Instagram as you've been building that. So I'd love to hear more about that.
Yeah, absolutely. So as you said that, I'm a perinatal and infant mental health counselor with a background in clinical psychology. So I have a PhD in clinical psychology. My passion is really about perinatal infant mental health and really serving communities that have been traditionally marginalized. I'm really active in the Black community, but also other marginalized communities, and as well as including the deaf and hard of hearing community. So I'm fluent in American Sign Language. Some of the things that I advocate for is, anti-racist approaches in all aspects of our mental health and really supporting the growth in mental health and social emotional development of children and families. I have extensive experience of working in NICU, PICU, CDI, CU, and helping support parents when their babies in those most intensive care units. And that's something that's really important to me. I'm actually on the advisory board for the National Perinatal Association has a subgroup that's called the Network of NICU Psychologists. So I serve on the Training and Education Committee. I am co-chair of that committee, where we are passionate about training future generations of psychologists to work in the NICU, to understand trauma-informed care, to decrease racial disparities within the NICU. I'm all about training and education, and that's the foundation, right? Like how people learn and how we can propel forward into our communities and have a better future than we have a present. Those are some of them. Yeah. And then on Instagram, right? So I'm posting everything mental health related, sometimes cute, fun stuff like our reels to get people thinking and smiling about it. And other times more heavy stuff. Recently, I've done a webinar that was called All Up in My Race that was really focused on really young children and how parents, teachers, mental health providers can start to frame social emotional intelligence from an anti-racist perspective. Understanding that not everyone has the right in our societies to express all their emotions and still be safe in doing so, and unless we teach the next generation how. So those are some of them.
That's such important work. And, as we see in our community, there's all sorts of different HIE impacts everyone. It knows no bounds. And so, all of this work is so critical when we look at, improving care and communication and mental health for, I keep saying the phrase, babies can't raise themselves. And, we need to have healthy parents, in, mind and body and spirit to really take on and live your best life, whatever that looks like. So
exactly. And I always love that you say that, because I think one of the questions that I used to get all the time, I'm an infant focused person, and they're like, you work with family, you work with parents so much. I was like, show me a baby that doesn't have a family or doesn't have an adult because I've actually worked a lot in like foster care systems. Like there's no such thing as a baby without an adult, right?
Yeah.
And so you have to understand how it impacts the whole family, because that family, that person, those people are going to be the ones that support the needs of the baby, right?
Absolutely. Yeah, that's so important. So I'd love to talk through, starting out about, kind of what the impact of trauma has on families in the NICU and PICU. So the event, the experience, and then that effect.
You just start on that. So I first wanted to just kind of think about what is trauma as we go into like the 3 E's of trauma, right? And so really, there's this fancy definition of trauma. So like the individual experiences an event or a series of an event or set of circumstances that maybe the individual was physically or emotionally harmful to the person or life-threatening, and that has lasting adverse effects on the individual's functioning, mental health, physical, emotional, spiritual well-being. But what I usually like to truncate it down to is when the brain perceives something as dangerous, significantly dangerous to yourself, to someone you care about, or when you've witnessed or overheard it for anyone else, because we can always think like, oh my gosh, that could have been me, or that could have been my family, or that could have been whatever. So when the brain perceives significant threat, trauma, that's a traumatic event. Now, just because it's a traumatic event doesn't mean the person or the family will be traumatized. And that's where we come in with the 3 E's of trauma, right? And so you just talked about event, experience, and effect, right? So the event itself is, again, that series or combination of things that could happen situationally. The clincher here is that, again, I think within NICU and PICU, we don't think about it, but you could observe or witness things happening to other families, other babies, right? Other young children. And that can either be one time, because you might see things like, I've worked directly in the NICU, right? I'm supporting a family, and then another baby that may be my family or not my family, the baby codes, right? Now this family, now they're like, oh my gosh, this is going to happen to me. They're experiencing what those parents over there are feeling. And so a lot of our NICUs and PICUs are open bay, what we call open bay, where you kind of go in and all the beds are in one room. And so you're constantly hearing alarms going off, right? You might be seeing emergency procedures happening. So those events, right, are all little traumas that you're witnessing that may not have anything to do with your child, but you're still experiencing those. And while open bay can be really great because it does help with community building for some families and able to chat with the other parents and other people in the NICU or PICU, it still can be potentially traumatic seeing those events happening in other places. Now, the E, how things are experienced, right? And that can be experienced by the person, like an individual or family, what have you. It goes into what I just said, just because something is a trauma doesn't mean you're going to be traumatized by it. So the factors we're really looking at here, whether or not you might be, traumatized by this experience, are going to be some of those things like cultural beliefs, spirituality, positive outcomes, having witnessed or experienced positive outcomes of that same kind of event, right? So can you trace back to, well, most of the time when this happens, ... everything's okay, right? Because that happens a lot of times in NICU, oh, no, that alarm is that just happens. That one doesn't mean anything, right? Because you become hypervigilant on what they mean. But then also social supports, which we'll get into that, right? So protective factors of having other people that can help support you through those events can be the difference between experiencing trauma and having long-lasting, traumatization.
Yeah, that's really, it's interesting when we pick that apart because, when we talk as parents and collaborate and share each other's stories and work to support each other in our peer-to-peer support network, it's all about people share every day about, this is months later or years later, and I'm still feeling this, what can I do about it? And, or there's a lot of, we have like, I think a form of survivor's guilt for a lot of our families too, whose kids might be, having a less impacted outcome than others. And then they're hesitant to connect because they're like, why, but they're still feeling traumatized or have, things to work through. And it's so complicated to, to kind of see how you are during a traumatic time and then how your brain starts to process it afterwards.
Yeah. I want to say, Betsy, that, I love that you brought that up, because one of the things that I really want families to know, I want the lay public to know, like I want everyone to know that the severity of like what's happening to the baby or the child in the family has nothing to do with whether or not the parents will or the adults will experience that as trauma, like whether they will be. So commonly what has happened, things have changed so much, right? So I'm grateful, but we still have to educate. Commonly what used to happen is like some of the providers in a NICU or PICU would be like, well, that baby's fine. Like they're going to be pretty much fine. It's going to be okay. Like, I don't understand why the parents are like flipping out. And what the data shows is that there's no correlation between like baby severity, medical condition severity and parent outcomes, because we're not considering all the other factors we just talked about. We're not considering their cultural beliefs. We're not considering their previous experiences or exposures to different traumas. We're not considering what else they've experienced while they've been in the NICU. We're not even, considering so working in perinatal, right? I've also worked in maternity. And, sometimes the birthing experience itself was traumatic. And so, they're still processing the birthing experience and you're just thinking about, the baby's going to be mostly okay, or, they're going to survive. And so that's a really key principle. So I want people to know that you can get help. It doesn't matter if it feels like, oh my goodness, but I should be over this by now. It's been years. No, it's okay that you're not, and you can get help and support for that. And what we look at from like a mental health perspective is when after onset, so, whatever the event is, when it's happening for a few weeks, we're like, okay, that's acute stress disorder, right? But once it's still happening, you're still having some symptoms, you're still anxious, you're still hypervigilant, you're still, worrying or waking up in the middle of the night. Once it's more than like a month, then we're looking at PTSD and iterations of PTSD or post-traumatic stress disorder. And what we know is that can be long lasting without supports, right? Mm-hmm. So it is perfectly okay to be years later and be like, I still have like, why does this still bother me? Why am I still feeling this? It's okay to reach out for help.
Absolutely. And there's so much, I think this is a great dovetail into our next topic, which is what is support, because there are different options for support. And, we, with Hope for HIE, obviously we support our families through a, pretty comprehensive peer-to-peer support platform, connecting currently over 6,500 families and, through different topic focus groups and location-based and outcomes and all of that. And that's one option. And mental health support is another option. And that looks very different. There's many different types out there. And it's really, I think we're working on trying to do a better job of communicating what are the parameters of peer-to-peer support versus, because a lot of times, and understandably, one of the things I think that our parents articulate very strongly is, that I don't have time to get into mental health support. But clearly having some really difficult time processing, trauma. And, peer-to-peer support is not meant to replace mental health support. So, can we talk through a little bit about what those differences and where that, overlap might be, from your perspective?
Mm-hmm. Well, one of the things I love is that there is overlap, but then there's also great opportunity for collaboration, right? So some people really need to be able to know that, be able to talk to people who've experienced it and who are comfortable talking about it, right? And even talking about it can be a healing perspective. So parents who've like been through this, they actually report feeling better when they're able to help someone else through those earlier stages, especially the community and the camaraderie that happens. You know, and I think that there's healing in that. There's some therapeutic value in that, absolutely. And I would hope that all, if not most, providers are encouraging peer-to-peer support, right? We are, through NNMP, which is the Network of NICU Psychologists, we are often trying to make sure that hospitals are talking about peer-to-peer support networks. We're usually trying to help them create programs and parent mentor programs so that they have connections with people that are actually in their area whenever possible. And what mental health support can do, right? It is a specialized person who's trained and experienced in helping with some specific symptoms and areas, but also it depends on the situation. So some of the things that I might do is work really closely with other providers in the NICU when we're trying to get parents to learn how to do things like bathing, holding baby, connecting and bonding, because what can happen, and I think people forget the overlap, excuse me, of HIE with perinatal symptoms, is we're looking at things like postpartum depression, we're looking at things like postpartum anxiety, and postpartum PTSD that were more related to the pregnancy and or the delivery or the birthing experience. And that is then confounded with babies in the NICU, babies in the PICU, baby went to see the ICU, whatever, right? And so, we're helping them navigate those different layers of what they're experiencing, from a mental health model or a clinical model in that way. So within mental health supports, it depends on your hospital, but we have what we call bedside service. Right, or we might be, that was one of my favorites, right? Like, so it's actually going in by bedside. And when you do that, you talk about there may be certain things that we're not going to talk about at bedside because you might want to disclose, if you're in an open bay, right? There might be things that you want to tell your NICU or PICU therapist that you wouldn't want other people to overhear. But we're also thinking about ways that you can support the mental health and growth of baby, right? And so you might be having a skin-to-skin moment with baby if holding is possible. And then we're talking about that experience and helping you feel bonded and connected. Because what happens a lot of times with postpartum depression is that there's a disconnect, right? There's a cognitive, I love this baby, right? But there's the often, I don't feel connected to this baby. Right. And then also with HIE, there's some families who don't want to get attached sometimes, right? There's that emotional barrier because they're afraid, I don't want to get attached to this baby, and then they die, right? And they're afraid to say that out loud very often. Yes. But usually they'll say that to either a trusted peer or a mental health provider, right? I'm afraid to say this.
There's a lot of shame. I think that self-shame for those, and those thoughts are so common. I remember that takes me right back to my own experience. And I know that this is articulated time and time again in our families when they feel safe to open up about that. And all of these thoughts that you feel, the sense of, of shame for even having that, because you love your baby. Of course, you want your baby to live and thrive. But, I think a lot of those common thoughts, they're human. It's that protective, like you said, it's that protective reflex where, you want to kind of, your brain can only process so much potential hurt. And you're just really trying to get through those moments, but you have these thoughts pop in of, would it be better if they passed away, for that? There's just all these things. And then you have that guilt and shame of even thinking that you would wish that upon your child, when there's really, it's a normal human experience and reaction.
Absolutely. Absolutely. Totally normal, totally expected, and doesn't make you a bad person, bad parent, because it's what's going to happen. Like, I don't think that there's a person who experienced these things and doesn't have some of those intrusive thoughts, right?
Absolutely.
It doesn't mean you don't love your child.
Yes, definitely. And we have one of our parents is commenting in about saying that it was so disconnecting to when feeling you were, pushed to pump all the time, and that, like that connection is just so, there's just so much complexity in that experience.
Yes, and that that makes me think about just sometimes the ways that providers do conflict, in the sense that I'm like, breast milk is great, it's wonderful, sure. And if this person who's pumping, right, is completely exhausted, further disconnected, having guilt and shame, right? What is that experience like for them, and how can they be truly supportive and there for their baby, right? It's hard to do that. You're asking, for, robotic things to happen, right?
Yeah, absolutely.
And so that's another place where often a mental health provider in the NICU or PICU comes in handy. So, and that could be different, just hospitals have different things, but like a social worker, all hospitals typically have a social worker. Some will have a counselor, some will have a psychologist. A few will have a psychiatrist on staff to help. But one of the things that I used to do is work really closely with our NICU social workers. And we would tag team, like, okay, which nurse is on? Okay, let's nicely talk to them about, like, we're not pushing mom to do XYZ. Be careful with your comments about why who such and such hasn't visited, or, oh, you're here alone again. Like, those types of comments. Like, your mental health support team can really become your advocates and a barrier around some of the providers who are a little bit, less informed. Because we rally. We're like, no. Yes. This baby and this family is a part of this family, and we're rallying for parents,
Absolutely. And I think this is such a great thing to bring up that, obviously, I think it's much more common with mental health providers to be, this really, this approach of trauma-informed care, and bringing these principles into, these situations that we know are traumatic for families. And there's a real push for all providers in the NICU to go through training. So I'd love to kind of segue into that about, talking through what is trauma-informed care and how those principles can be applied across any discipline to best help support families.
Excuse me. So yes, trauma-informed care really has what we consider 6 principles, right? And like you said, these 6 principles can be applied through everything. Like, you can have trauma-informed yoga, right? You can have trauma-informed anything. And so we're going to kind of go through the 6 principles. So the first one is safety, right? And if you really, the way I like to think about safety is, most of us have heard about, like, our basic physiological needs, right? So, like, food, shelter, water, body temperature regulation, things like that. And if your basic needs are met, then you can get some of those higher order things, right? If you are unsafe, if your environment feels unsafe to you, if you feel like you can't, appropriately say, hey, this pumping is too much, right? You can't build any of the other, you're not going to do a really good job of being able to build the other things or think about the other things, right? Because you are just trying to be in that survival mode, right? So within trauma-informed care, being able to create an environment that feels safe for whomever's in that environment is like the base level thing to do. And again, that looks really differently across settings. And one of the things that I think about for safety, and this might surprise you, I don't know, but one of the things I did in the NICU was have an emphasis on men, people identified as male, and wanting them to feel supported and safe in the NICU. And so we kind of looked at, why, what are their barriers to feeling safe? And honestly, they felt like it wasn't geared for them, right? It wasn't pushed towards their gender, and it wasn't something they weren't allowed to have feelings about it. They weren't allowed to express like their own, that they were scared, that they needed help or support. They thought that they had to be like stoic or weren't even welcomed in or couldn't ask certain questions. And so like, how do we create that environment? Like one of the simple things is like, well, we didn't have any pictures of like dads or men up in our, like have all these like, pictures of like women holding babies and like, there's like nothing. And it's like, oh, so you don't even feel safe because you're not represented. I get that, right? Because a Black person, I'm often not represented. Duh, that makes sense across gender. So safety is like number one. Number two is trustworthy and transparency, right? And, that kind of goes back into how are you using some of the information that I tell you, right? Can I trust you to listen to me and like actually like pause and listen to what I have to say? Or are you going to brush me off because, in NICU PICU, like you just think like, oh, this is just, a mom being a mom, or you're just anxious or whatever. This means nothing. Are you actually going to listen to what my concerns are? Are you going to be transparent with the information that you provide me? Right.
This is such a huge one with our community in particular, because a lot of times we still have providers that are hesitant to even name the diagnosis. And so we bucket this as we've, really been doing a lot of work around learning about trauma-informed care and collaborating with different people that are in the NICU. We need to be given as families as much information and then decide what we want to do with that, but withholding that is a barrier to trust. And that is one of the things I think that is so strongly articulated by our family, is that, the ones that see this diagnosis on discharge papers or later in their, child's medical records. And it's like, this is such a moment, regardless of how you got there to the NICU, and we really encourage, especially the neonatologists and pediatric neurologists, like this is that moment that you can start building this trust with families by being transparent and naming the diagnosis.
Yep. I am saddened that people are still leaving the hospital without knowing, seeing it on discharge papers instead of having had the conversation. I don't know why that's surprising to me, but it is, and it makes me sad, I think it's because I work in like the training and education side. So one of the things that we are actually running a study on, and we developed a program about like trauma-informed care and teaching neonatology fellows how to navigate and have conversations, how to approach families from a trauma-informed approach. And so I'm like, no, because I'm teaching people how, but I'm like, obviously not teaching the whole world. But yeah.
And there's so many people that are passionate about it and doing, great work. And it's like the question that we have a lot is, how do we reach those that need to? That's really the difficult thing. is how do we tackle that next?
The good thing, all the things about the pandemic. One of the things that I have found to be good is that the training that I was just talking about, we were able to do it over Zoom, right? Which just meant we had more access to some neonatology fellows across the country instead of just doing it in the home base of where the study started. So, that's something. Obviously, it's really different because hopefully people are able to be back in NICUs and PICUs and all those things in person with their providers and their families. But at least we reached,
It's amazing. Yeah, that work is so, so needed.
Yeah. So the third principle is what we were talking about earlier, peer support, right? And again, because it's so important that, you have people who've been through it, who can talk to you about it, who can experience that, to let you know that like, yeah, those thoughts are happening. Like, so it's one thing to hear it from me when I tell families like, oh my gosh, it's so normal. I work with families all the time, or have this experience. And I was just like, yeah, and they might believe me, feel it, but it's another thing to hear it from someone who's experienced it, right? And then like, oh, right, then that ties back to my therapist did say that, right? Like, my therapist was being trustworthy and transparent. It was honest with me. Okay, now my peer support person saying the same thing. Just vital in that care. And also, one of the things that's really helpful for peer support is, you can learn about different ways to navigate systems, right? Because people will often be willing to be like, well, this is what I had to do. Here, I had to create a binder, right? To like go in and talk to providers because other people didn't know, like all these things. And I'm like, oh, that's really helpful. I never thought about that, or I didn't, like, that's such a good thing. People will give you templates for things, right? Like, no, I don't want you to have to create this all on your own. Like I've done this. And that's just it's invaluable, right? We can't even put a real label on that. So needed. And then collaboration and mutuality. And for how we look at this is really, again, I always like to think as a provider, I don't believe in the whole, like, I'm an expert on blah, 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 right? We are working together to help you, meet your needs and meet the needs of your family. You, like, as a family, have so much, you have all the insight into like your life, into your needs, into how things work. So we have to work together, and I'm not talking down to you. And so I think that some medical providers are still learning this piece for sure, right? But making families feel included in the conversation, making families feel not even just included, but like that their input is the most important input, honestly.
Right. Yeah. And moving towards family integrated care, that I know is getting a lot of buzz, which makes sense, right? I mean, so many families talk about their own medical needs that, they ignored because their child's in the NICU, and then that creates other issues, and, it kind of snowballs. And then on the flip side, we have a lot of conversations with neonatologists, and, a lot of them are so wonderful to talk about their own vulnerability with having these conversations, really difficult conversations that typically have to happen with our families. And, they express when they're able to, be vulnerable and authentic about how they're feeling. I think that just creates a much more open and collaborative environment to say, this is hard for me too. I don't, I'm still navigating, these are providers that have been doing this for years and years, and it's still hard for them to, give not optimal news, or, communicate a difficult diagnosis, or, difficult prognosis potential, or diagnostic information. And they are, they truly care about this work, and many times just don't know how to do it any differently. So, but I think, and I encourage when we have those conversations to say, that makes you human, and this is a human experience, and opening up about that goes a lot further to build that trust than, anything else, when we can come together and collaborate like that.
Yeah, absolutely. I think, the other piece of like that you talked about is the like families will often like neglect their own medical needs, right? Because they have a child in the NICU or PICU. And that's one of the reasons why I was really fortunate to be in a hospital that was creating and cultivating NICU mental health services for the families. So we did like screening for depression, anxiety, and trauma symptoms in the NICU. And as a routine standard, like, this is a part of you have a baby in the NICU? Okay, like, we're gonna screen you for these. We're gonna let you know about these services. We're gonna check in. You're gonna see my face on the unit. Because the likelihood, people were will miss their appointments because they want to be at bedside, right? They will. So if I can be in the hospital already there for you, you're a little bit like, we can just go right down the hall. Like it's 10 feet, and I can have the nurse page me, right? And we can just go running if we need to. That's so much easier to convince someone than to like go to a different hospital sometimes, right? Yeah. Some of these families, I was in like a level 4 NICU, which, the catchment area is really big. Some families were from out of state, right? And they're like, I'm not, whatever, that appointment, whatever. So yeah, this whole like collaboration and family-centered, family integrative care is, part of the trauma-informed approach.
Absolutely.
and then empowerment, voice, and choice, right? Which, there's some overlap there, but I think that one's kind of self-explanatory, but really we're trying to make sure that the family or the person involved feels empowered to make informed choices and decisions, right? And that's where they needed that like transparency and trustworthiness, right? So they're trusting that you gave them all the information that they would need to like make a decision about something. And then they have the power to use their voice to make these decisions, to make the appropriate choice, feel empowered to like say, no way, yes, whatever the case may be, and empowered to even ask more questions.
Definitely.
Right? To know that they're a part of that process.
And I think sometimes reminding the team and advocating for yourself to say, I need time to process this, and I'm going to need to either have it completely told to me again. I think the notion that people can just take on and react quickly to information is just not, it's not reality. And we can all do a better service to our own well-being for saying, that was something that I've had to learn, and people coached me on too, of saying, it's okay to say, I need a break. I need time to process this. I don't want to react and say anything right now. Can I have some time? And that has been, a huge learning curve, but that is that, then you feel empowered that it's kind of coming back when you feel, you can advocate for the way that you like information or need information, and the timing behind that too.
Yeah. I'm going to be honest. My the first times I was ever on a unit, and I would do rounding, and, we'd do rounding, we'd try to wait for the family to be there. And I'd be like, and I knew sometimes what was going to be said or like some of the ideas. And I'm like, I couldn't process the information. Right. And so I'm like, what in the world does this parent know what's happening? Cause I have no idea what's happening. And so sometimes we're like, oh, could you repeat that again? Cause I'll see like the family also looking like, I'm like, oh, could you say that again? What exactly does that mean? Right. And then I think in having some of those conversations with families, are like, oh, you can ask those questions too. Like it is perfectly okay to pause and be like, you know what? I'm going to model this, and I'm going to like, be the person that's like disrupting rounds that are supposed to be so quick. But it's a time for you to be able to ask questions regardless of what, others may think sometimes. And I think, honestly, like you said before, providers are there to support the family. They love what they do. They sometimes just don't know how to do it. And so when we can just say, hey, they just need it one more time, they're just like, oh yeah. Like when they think about it, so absolutely makes sense. We'll slow down, or we'll repeat that, or we'll say it differently. I feel empowered to say that.
That's so helpful. Thank you for walking through that. And so when we look at, how we, oh, sorry.
No, it's okay.
Like I was counting through. I'm like, was that 6?
That was 5. That's okay. The last one is just cultural, historical, and gender issues, and like making about that. And I always think, I actually think that they shouldn't be ordered this way. It's a whole other thing. But I think that should be, synonymous with safety. Right. I know that they're thinking about trauma-informed approach from like, these are things we should be considering, right? And making sure that, we're looking at historical impacts for different communities. But I actually don't know how we create a safe environment if we aren't also thinking about someone's culture, historical experiences within a system, gender, all those things. So, but it's there, and that's what it's for. And I'm glad that it's there, and it wasn't always there. So.
Absolutely. And, that's one of the things we really try to create space for all different types of family dynamics and family supports. And that has come from the expressed needs of our community too, and saying, hey, can we have, a space for, for single parents and for, families that identify in a certain way. And it's, that's been one of, I think, the things that I've been so happy to see our organization embrace, is just so, like we want to do the best for our families, and we talk about holding space, and sometimes it's creating that space and making sure that people have all of those things that they can, feel they can open up and connect to other people with similar experiences.
Absolutely.
And working with, providers to do so as well.
Yeah,
definitely. All right. So then when we look at, connecting families to resources, looking at, in the unit and then upon discharge, what are some of the things that you would recommend to other providers to do, like, as people are getting ready to go home, or perhaps, their child did not survive the NICU, and, how we provide resources in those situations.
Absolutely. So what I would ask first providers to do is to think about it as a part of the course of being in the NICU, and that it's not just upon discharge that we have some of these conversations, right? And so we know that we know that sometimes what happens is that, we give out brochures, right? Or we give out like a little binder, a little booklet. And then we're like, we've given that information. And that is great, and that needs to happen. And it's wonderful that sometimes there's like a NICU or PICU orientation people, hospitals will do. Check in about that, what feels like in a couple weeks, a couple days, whatever the case may be, depending on how long that like NICU PICU stay is. But it should never just be the first one and done, right? Because as we've just talked about, sometimes people aren't even processing the information, or, if there were several brochures given from several different disciplines that are like about different things, they might not have even looked at that stuff, right? Like they were like, I'm trying to be with baby. So I would suggest that just checking in. And a lot of times, this is having a point person can be really helpful. So someone who is not kind of knows like, okay, I'm going to just check in on these things. Sometimes that's like the social worker. Sometimes that's like the nurse, one of the nurses. Depends if they do like primary care versus like dispersed care in the NICU or PICU. But having a point person on the unit for that family who can just go over like, hey, here are some supports. I'm going to check in about this again, right before discharge. Make sure you have this information. We also would recommend, sometimes families will say no, but is it okay if we reach out to you, or if it's another, like some of the peer-to-peer support networks will reach out to families. And so like we'll say, we can coordinate that if you're okay, we'll give them your number, we'll give them your email, whatever, and they can reach out to you. Because what also happens is, again, managing certain types of appointments becomes more important than their own mental health or their own like emotional stability. And so there was a quote that a family said one time, like, if someone had told me to like, oh, there's a peer support group even in the hospital, I wouldn't have gone. If someone had come from the peer support group and said, hey, we're about to start a group, and so all of us have experienced this, then I would have probably come. Right? Because it was the difference of me having to actively go do something than it was for someone coming to reach out to me and taking that burden off of me, and me not having to worry about what time it was going to start and all those things. So I would have providers do that if that's possible. Just ask for the family's consent. Like, can someone reach out to you once you're home, and just offer you, let you know more about these services when things are home. And then the other thing is keeping the door of communication open. And I think providers do this pretty well most of the time, but we can always say it again. But just saying that sometimes when you get home, you think things are going to be fine, or like, I'll be okay, I just want to get home, right? That's sometimes that's the big thing. I just want to be home. And I think people should be prepared that sometimes getting home actually increases. There's like evidence that shows it increases anxiety for families like with HIE and like NICU and PICU, because then you start to realize, oh wait, I don't have all the monitors, I don't have all the people, like, sleeping gets harder. Like, wait, what's happening, right? And so sometimes being just preemptively prepared for that, like, okay, this may happen. You may get more anxious. You may be more worried. I can't remember the stat, but like even when baby's pretty much okay, I think it's like 40% of people return to the emergency room.
Mhm.
And not necessarily because the baby needed to be in the emergency room, but like that anxiousness of like something, this can't be right, or like, there was a monitor before to tell me this was okay.
Yes.
So letting them know about that, making sure they have the number to, most hospitals have like a nursing line that will be able to say like, oh yeah, bring them in. Oh no,
Mhm.
don't. But don't just, like, oh yeah, you're going home. And it is a celebration. And it's also like, it's okay if more feelings come up.
Mhm.
Here's how here are some resources you can be connected with. So I guess like preemptively letting them know that, yeah, this is really great and you might be really scared.
Right. Yes. You can feel many things at once and do.
Yes.
Yes. Absolutely. And that's a hard thing too, is just, wow, I should feel a certain way, but I'm feeling this way and this way instead, and I think again, it comes back to that, you know, having someone else affirm how you're feeling is normal, and it's typical as you go through this.
Yes, absolutely.
So important. All right. So I think as we start to wrap up, talking through just like any other last recommendations, we've covered a ton of ground this whole time, but just encouraging families, seeking full support, whatever their family dynamics are, and their demographics. We alluded to that a little bit, but I'd love to hear your take as you're, talking through like kind of recommendations to parents and caregivers and whoever those, adults are in that situation.
Yeah. I think one of the things that I want families to know, that it's okay to set boundaries, even with the people that you really, really care and love you, and that you love. Um, when it's okay to like check out from well-meaning people when they say things like, if you feel like they're exhibiting a little too much like toxic positivity, or when they compare like their baby's like one day NICU visit that was like for observation to anything that you've experienced, and you're just like, this is not the same thing. Or like, I know you're trying to connect with me, but like I crawling out of my skin right now. It's okay for you to just, just take a pause on that conversation, or set some boundaries in place for you, which I know that's like easier said than done, right? You care about these people, whatever. But I want to say that because sometimes people do it and then they still feel all this immense guilt, right? They'll like set a boundary and like, oh my gosh, I'm a horrible person. Like I know they were just trying to do these nice things for me. And it's like they were trying to do something nice for you. And so what? It didn't land right. And you were affected by it. And it's okay to take a pause from it.
Mm-hmm.
It's also okay to accept help and support. So I think a lot of people, depending on like where you are in the world and what your like societal beliefs are, but I know here in the US, a lot of us have this like this overly independent mentality that tells us not, if we can't do it all and like look like we're doing it well and look like we're feeling well about it, then we are complete loser and failure and we're weak. Like it's like, and it's just all or nothing. And so then we're less likely to ask for help, right? Or less likely to like accept the help that's offered. And so can't do it alone, and it's okay, right? It's okay. It's normal. Like takes a village to raise a child, even on, the best days. So go ahead and accept the like food train that people may offer. Go ahead and accept, whatever types of help is culturally relevant to you, that feels appropriate and supportive. It's okay to accept that. It doesn't make you weak. It actually makes you strong, right? Because asking for help can be really challenging. It's okay if, don't let anyone make you feel like the boundaries that you're putting in place are extreme, when people like, whether it's like hand washing, for example, like it's okay that you want people to wash your hands. It's your baby, it's your family. You want to keep them safe in that way. That's how you're like approaching safety. Go for it. What else did I want to tell families? what I would tell families that are from marginalized backgrounds, right? I think a lot of times we know this, but sometimes you might have to advocate really hard for basic level care, and that's okay. And don't let anyone tell you that you're advocating too much for the care of your child or your needs. If you are really feeling like the answers that you're getting are vague or inappropriate, keep asking. It's okay to get another opinion. We just know the history in our world, honestly, that the care that's provided to people from marginalized backgrounds is less than that's provided to other communities. And especially when there are language barriers. So if there's any different languages spoken between you and some of the providers. I've had families like, well, I don't want to be a burden. They didn't offer me an interpreter and I don't whatever. No, it's okay. You deserve the interpreter at your bedside. You deserve an interpreter. People don't realize it's not just for those major meetings, care rounds. You deserve an interpreter at bedtime if the nurse wants to say something to you and the language is different. Even if you I kind of understand. No, you're allowed to have full access to information about the care of yourself and your family. So it's okay to be like, I want an interpreter at bedside, or the nurse wants to say something. Thankfully, a lot of hospitals now will have even on the iPad, the virtual, they'll roll in a little interpreter on an iPad. You can ask for that. And once you've asked for it a couple times, guess what? They will just know to bring it. That's the good thing about it. But it's okay to advocate for yourself and without feeling like you're going to be a pest or going to be labeled as difficult.
And it takes practice. I think that is something that is a good learning is that it's, if you're not used to it, it might feel really uncomfortable the first several times you set a boundary or, advocate for something that you need. And you're going to feel like you want to question, you're going to question yourself if you're doing it correctly. But the more that you practice, the more empowered you'll be to do it when it really counts too.
Absolutely. And if I can give one takeaway message, I would say that throughout all of this, throughout your experience, whether it's in the NICU, PICU, birthing experience, when you hear yourself second guess yourself, when you hear yourself that wasn't okay, when things are feeling awkward, I want you to ask yourself, what would I tell a friend in this situation if I wanted them to feel better? And then I want you to really think about that. And I want you to say that exact thing to yourself. The reason is there's evidence that shows that we are kinder to others than we will ever be to ourselves. So if you have to treat yourself like your best friend, if that's going to work, please do it. But what would I tell a friend? Right?
That's such great advice.
Yeah.
It's so helpful. Well, we are coming up on the hour, and I want to thank you so much for sharing today and, working with us on hope and all the great work that you do, especially, I know you are such an amazing advocate for accessibility. And it's something that I know I have just learned so much personally from you and continue in our quest, to be as trauma-informed, accessible, et cetera, to best serve our community and more people out there. And I just want to thank you again so much for all the work that you do in this space and the positive impacts that you make for so many families.
Thank you. Thank you so much. Thank you for having me. Thank you for collaborating. And thank you for hearing my ideas when I know sometimes that they're new or different, right, than what you've been exposed to sometimes. So.
Absolutely. I love it. So, all right. Well, and everyone that's been watching, thank you so much. And we will connect with you soon.
Bye.
Thank you for joining us for another episode of Hope for HIE's official podcast, Just Say HIE. If you have a story you'd like to share, be sure to keep in touch. Learn more about the work we do and sign up for our newsletter on our website at hopeforhie.org/justsayhie. We look forward to connecting with you soon, and thanks for listening.